Hi guys, and welcome back to Tongue and Check.
In your PEDS examination, you should always be on the lookout for a rash. If you manage to work out what's causing the rash based on what it looks like, you'll be rashing ahead.
Nearly all babies will be faced with a rash at some point, but you need to know the difference between the bog standard nappy rash and something like Scarlet Fever or purpura, where no amount of tubs of E45 will touch the sides.
Now, it's quite hard to describe lots of different rashes without showing you loads of pictures, and even then you're still much better seeing them in the flesh. So we're going to revise the key things to look out for to help you differentiate between the causes.
Let's start with infective causes of rash. A non-specific viral rash is really common in young children. It's just a light maculopapular rash and coincides with viral illness, as the name suggests. It will clear up within a few days.
Fifth disease, aka slap cheek disease, affects young children and is due to parvovirus B19. The child looks like they've been slapped around the cheeks, which are red and hot, and there's a lace-like rash on the limbs and trunk.
Sixth disease, or roseola infantum, gives you a rosy pink or red raised rash on the trunk, as well as coryzal symptoms and a whacking great fever, often up to 40 degrees.
Hand, foot and mouth disease, not to be confused with foot and mouth disease, which was rife among cattle in the noughties. It mainly affects children under 10 and is caused by group A Coxsackie virus and enterovirus 71. It's transmitted by direct contact with skin, fecal-orally or other bodily secretions like snot, and as the name suggests, you'll find vesicles on the hands, feet and in the mouth.
Scarlet fever, caused by group A strep. There's quite a typical pattern to this one. It starts off with a fever for 2 to 3 days, followed by a headache and tonsillitis, then a sandpaper rash with peri-oral sparing, the classic strawberry tongue, and cervical lymphadenopathy. Treat this with PEMV to prevent glomerulonephritis and rheumatic fever.
Measles, part of the MMR vaccine, so not as common as it used to be, although there are fears of it making a comeback. Caused by the measles virus, and there's a risk of some serious complications like meningitis, encephalitis, pneumonia or eye and ear problems. There's a prodrome of fever, malaise, conjunctivitis, cough and coryza, and the giveaway signs are the conflict spots on the inside of the cheeks and a rash that typically starts behind the ears.
Similar to measles, but German, rubella. It's now very rare thanks to vaccination, and it's quite a mild illness with few signs and symptoms.
Chickenpox. We've all been there, or you should have if you haven't been by now. I think we'd all spot this one. It's a vesicular rash that's super itchy and then scabs up. It's caused by varicella zoster virus, and there's not much you can do about it other than to try and stop scratching. Calamine lotion, short nails, gloves, etc. No ibuprofen though, as it can cause skin infections.
So those are what we think are the most important infective causes of rash you need to know as a medical student. We're also going to touch on purpura, which is a rash of non-blanching purple spots due to internal bleeding from small blood vessels.
The best way to think about purpura is by measuring 2 factors: how well they are and how many platelets they have, not just specific to PEDS. Ill and low platelets is meningococcal septicemia, so get on with your sepsis 6. It could also be DIC or leukemia though. Ill and normal or high platelets is a viral cause or vasculitis like Kawasaki. If they're wellish and they've got normal platelets with no history of trauma, it's Henoch-Schönlein purpura, and that's my all-time favourite word to say. It's an acute immune complex mediated vasculitis, and most patients have a preceding upper respiratory tract infection. There's a classic triad of purpura, arthritis or arthralgia, often in the knee or ankle, and abdominal pain.
You can also get some renal involvement, scrotal edema and intussusception. ESR and IgA are raised and protein can be found in the urine. Most cases recover in 2 months, but you have to watch out for complications which are worse in adults: GI bleeds, ileus, hemoptysis and renal failure.
And lastly, if well and low platelets, think ITP, which is the most common acquired bleeding disorder in children. Most patients have some preceding illness and are left with this rash afterwards. 80% gradually resolve over 3 months, with the other 20% lasting for more than 6 months and needing more intervention. So steroids to suppress the immune system is the first port of call.
So in summary, those are the main causes of rash in kids. We haven't discussed eczema as it's more dry skin than a rash, but the answer there is E45 until the cows come home and keeping as much moisture in as possible.
Thanks for watching, I hope you found that useful. See you next time.
Bye!